Just give me 1 minute, man.
ॐ गणपतये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया।
ॐ गणपतये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया।
Sharing rights, I will start the prayer. Yes, I prayer.
Hello, we're not able.
Yeah, Jignesh, can please give me a sharing rights? Yeah, okay, fine.
So before they start, I would just, on behalf of the Endometriosis Society of India, warmly welcome all of you for the Module 3 of webinar series. Really grateful for the overwhelming response and continued participation across all modules. And I'm very grateful in coordinating this webinar series. And it's been a very encouraging to see such enthusiasm of learning and advancing and understanding of endometriosis. I would like to take this opportunity to sincerely thank our esteemed faculty participants for their valuable time, support, contribution, make series a success. Look forward for another engaging session today. Pallavi, are you ready for the SI? Pallavi?
We shall overcome, we shall overcome, we shall overcome someday. Oh, deep in my heart, I do believe we shall overcome someday. We shall overcome, we shall overcome, we shall overcome someday. Oh, deep in my heart, I do believe we shall overcome someday. We walk hand in hand, we walk hand in hand, we walk hand in hand someday. Oh, deep in my heart, I do believe we shall overcome someday. We walk hand in hand, we walk hand in hand, we walk hand in hand someday. Oh, deep in my heart,
Pallavi?
Yes, ma'am. Yeah.
Yeah, can you share the screen for the CV of sir?
Yes, yes.
I would like to introduce the chairpersons. So it's my pleasure to introduce our esteemed chairperson for today's session. First, we have Dr. Pradeep Kumar Mitra sir, a distinguished name in the field of endometriosis. He's the founder and secretary general of Endometriosis Society of India and past president of Bengal Obstetrics and Gynecologic Society. He has dedicated over 2 decades of his career to advancing the understanding and management of endometriosis and adenomyosis. He was the organizing secretary for ICE 2025, the International Conference of Endometriosis. Dr. Mitra sir has 17 journal publications and several books to his credit and has served as international faculty with FIGO, ACE, and AOCOG, SUD, and AFOG. Among others, he has been associated with prestigious institutions including the University of Illinois, Chicago, USA, Uchida Hospital, Japan, and has also been a visiting endometriosis research fellow at UBC, Canada. He is currently serving as a principal investigator for the NHS Southern Health Foundation, UK 2024 to 2027. With numerous publication and global academic involvement, he continues to be a guiding force in endometriosis research and education. We are truly honored to have you with us, sir. Joining him is Ujjal Bose, an accomplished Pallavi. Ujjal Bose, an accomplished academician and researcher. He's an associate professor and course director of fundamentalist in pharmacology at at Manipal American University and has completed his PhD and postdoc in oncology from the University of Nottingham, UK. He explores tumor microenvironment dynamics and epigenetic regulation of KCNK9 channels in ovarian cancer. He received the Distinguished Visiting Faculty Fellowship to develop curated tumor microenvironments and 3D tumor constructs for gynecological cancers and was an academic visitor for research in female reproductive health. His collaborative studies include work on cervical cancer involving NLRP3 inflammasome modulation by chitosan, nanoparticles, and a UK-based study on preterm birth evaluating bacterial toxin induced NLRP3 activation in trophoblast cells from placental cord blood. International advisor for ICMR approved study on the development of non invasive urinary microbe based biomarker of endometriosis. He is a co PI for a Rotary Foundation supported study on the development of FNIRS EGPPG hybrid modality for diagnosis and monitoring of stress and associated inflammation in endometriosis. As course director, he integrates pharmacology education with ESMLE preparation and innovative student success program in molecular mechanism of drug molecules used in endo-reproductive pharmacology. He also mentors research on AI-based stress reduction and a recipient of patent and an advanced parental drain device to promote wound healing and inhibiting biofilm development through nanospike-based strategy. We are delighted to have you with us, sir. Over to the chairpersons.
Harshini, 1 second. Mitra sir is not able to unmute. So request the tech support to unmute. Can you hear me? Harshini?
Yes, sir. Yes, ma'am.
Pallavi,
Yes.
I
Yeah,
tell
ma'am.
Dr. Mishra to unmute himself. He is not able
Okay.
to unmute. Okay?
Yeah. Jignesh, please help Dr. Mitra. Jignesh, are you there in the meeting?
Yes, ma'am. Sir has
Please,
unmuted,
yeah.
but sir is not speaking anything.
Sir, I think
Okay.
it's our speaker.
Sir, I think sir's mic is not working. Hello? Pradeep sir? Pradeep sir's mic is not working.
Hello, am I audible?
Yes, sir. Just sir, you are audible.
Thank you.
Hello, Pradeep sir? Pradeep sir, your mic is not working. I think you can log out and log in again. Sir, if you are connected with external mic, hello, Pradeep sir. Hello. Sir, your voice is not coming. Your mic is not connected. Please select the appropriate mic in audio. Click on audio and select external mic. You see there is select microphone system. Select your mic. Pradeep sir, if that's not happening, you can connect with the mobile, sir.
Good afternoon, Prabhu. Good afternoon. Good morning, Ujjwal.
Good morning. Good morning. Good morning.
Good afternoon, everyone. This is Avinivesh from Calcutta. PDM sir, good afternoon.
Hello, Avinivesh. How are you?
I am fine. How are you, sir?
Successfully on.
Great, great, great. Shuranjanda, how are you?
He's always fit as ever. Suranjan, can you unmute yourself? Please unmute yourself.
I'm already unmute.
Good.
Can you hear me?
We can hear you, but we can't see you.
Yes, sir.
Hear you, but we can't see you.
Okay.
Yes. Yes, sir.
I
You
think-
are now visible.
Yes, sir. You are now visible. Now I
Sir,
am
just-
visible and audible. Okay?
Sir,
Yeah.
just log out from
Yes.
the computer.
Yes, yes.
Sir, just log out from the computer.
Yes, yes.
I think now I am audible and visible. Okay.
Yes,
Yes,
sir.
sir.
Okay.
Yes,
So thank you very much, Dr. T. Ramani Devi, for this particular series of course. Now about VSI, I am supposed to say a few words, which I told in the last occasion. Our ASI had started in the year 2003, and the brainchild of late Professor B.N. Chakraborty, which has been nicely implemented by our present President and founder Secretary General, Dr. Das Mahapatra, and I had the chance to work with him for a long time at Deputy Secretary General. Now, our upcoming programs, one is one day on endometriosis, which will be held probably on 18th May at Trichy. And Dr. Ramani Devi has been taking a lot of initiative for that. And apart from that, our new chapters might be open there at Faridabad and Trichy probably. And in this context, I would like to express my heartfelt thanks to Tamil Nadu Federation of Obstetric Gynecology for arranging the credit points. Now, this particular seminar, this particular session is very much important and most attractive because it is just like a live workshop by the experts, surgeons from all over India. Now my one request to all of you that it is an extensive course and it is meant for general gynecologists and postgraduate students. So it is being requested all the eminent speaker to stick to the basics and the current acceptable concepts, ideas, so that a clear message may be conveyed to all the viewers. And of course, the new areas or new researches might be included. Of course, that might be done. And secondly, I would request Jignesh and to the speakers to stick to the time of 20 minutes, and would request Jignesh to just give a signal when 2 minutes is left for each speakers. And then if there is any technical problem, that's what happened for me right now, we'll give him 2 minutes for sorting out this problem. If it is not solved, the next called upon to speak, and he or she may send the slide to Ramani Devi or Jignesh. Now, may I pass on to the first speaker, Dr. P. Das Mahapatra. Can I see the slides of, introducing slides of Dr. Das Mahapatra? Actually, there is no need to introduce Mr. Das Mahapatra. I have already said he is the founder of this particular society, and is working a lot for this society. He's a great academician. He's a teacher of all teachers in the Eastern region in endoscopic surgery, and I'm proud to have him as my endoscopic surgeon. Apart from this skill, academic things, the other areas are remain, which I must mention. One is he's a very good actor, writer, poet, and not only that, probably none of us have achieved that area. He's a licensed pilot in aircraft. I think none of us has got that license. So anyway, I am not reading this brief biodata of Dr. Das Mahapatra. I don't think it is necessary. Now, his topic is surgery for endometriosis, and we all know that anatomy of human body never changes, but except the rare anomalies and the endometriosis study. What do? We just try to do to normalcy of the changed pathological anatomical areas, so that a change, to come back to the normal anatomy can be restored and the functional status can be restored to the vital organs. And the learning curve of endometriosis surgery is very, very steep. Now, with these few words, may I request my mentor and the teacher of endoscopic surgeon to give his lecture. Sir, please carry on.
Thank you. Thank you, Pradeep, for your elaborate introduction. I'm trying to share my slides. If you give me 1 minute, please. Can you see my slides? Hello?
Yeah, I can.
You can see the slides. Wonderful.
You
So,
click on the entire file is being visible over here.
Is it visible now?
No, sir.
No,
You selected
not
the
like that.
Explorer window. Just stop sharing and select the first option. Stop sharing. Click on a share, and you see the first option, entire screen. Just select it. First option, not application, entire screen. And share, sir. Yes, sir.
Yeah.
Now it's visible. Just make it in a presentation mode.
Full
Yes,
screen.
it's
Yeah.
perfectly fine.
Is it okay now?
Yes.
Yes,
Okay.
sir.
Okay.
Okay. Now, what I'm going to talk about this today is that first of all, I think it is very important to talk a little bit about the history of this management of endometriosis. Then we'll talk about why surgical, why not medical, and infertility, which one is best, and then we'll draw our conclusion on this talk. And then of course the MCQ, there will be 5 MCQ questions, which I have already sent to you. Now, in 1950s, we depended on progesterone and testosterone, etc. But the surgery was there, but it was an open surgery. I remember in 1960, new progesterone came when everybody switched over to new progesterone. And 1970, second and third generation of progesterone came into use. And then 1980, early danazol and Insulex, that was available in the market, and we thought we found a panacea for treatment of endometriosis. But nothing happened. We used for some time, then we found all the side effects, 15. So what happened? We went for diagnostic laparoscopy, which was randomly used to diagnose the case, particularly in infertile women, when we found that endometriosis was associated with these infertility persons. In 1980s, late laparoscopy surgery started. We started doing in 1980s, late, this is after 1985. And 1990, in the early period of 1990, there was competition between surgical management by laparoscopy and IVF. At that time, both the methods were newly available to the surgeons, and they picked up randomly without being controlled or monitored by anybody. But 2000, both the members came to compromise the situation. We decided that we should sit together and decide which one is best for the patient. Then we come to this. Now recently the pendulum is swinging towards the medical management. There are many reasons. Newer drugs are now available. Improvement of ART technology, definitely. Surgery difficult to learn and execute. That is very important. To master the surgery, which is a very difficult and complicated one, you have to learn, give a lot of time, and we also understand the adverse effects of surgery. And there is no guarantee that it is going to cure the patient. Not many endosurgeons are available now, although in India we are having quite a number of very reputed surgeons for endoscopy management of endometriosis, but still we need people to do this dirty job. It is dirty, I'm calling it dirty job because of the fact that it is really, if you see the pelvis of advanced endometriosis, you'll be surprised that all the things, all the nervous structures are friendly and they are tied together. They are glued together. They want to go in a group. So it will be very difficult to dissect out the rectum, colon, and also fallopian tubes, ovarian tissues, preservation, everything is becomes so difficult. Now, even then, we have still, although there is a swinging of the pendulum towards the medical management. Medical management, we discussed why, but then there are some areas where we have no other choice but to do the surgery. Now, diagnostic to ascertain the stage of the disease, diagnostic laparoscopy. Although it is said that it is no longer the gold standard, but I do not know why the people say this. Now, if you want to publish a paper on endometriosis, they will ask you whether you have confirmed diagnosis by laparoscopy. If that be the fact, how can the laparoscopy scope is dying? This is number one. Number two, we have seen this, yes, pain is not a good parameter of sign of endometriosis. So the endometriosis can be diagnosed confidently with diagnostic laparoscopy. Now, of course, when the medical therapy fails, you have the choice to do surgery, and endometrium with pain is more than 5 centimeter diameter. That is no longer true because nowadays we can use new drugs, that is anti-GnRH antibodies, and we can use that if it is more than 5 centimeters. Recently, I have seen one patient who had 7 centimeter diameter, and I have used this antibody, anti-GnRH antibodies, and there is much reduction. Patient came yesterday to consult me. We found there is a lot of reduction. However, it is not clear whether she is going to have a hysterectomy in near future or not. Now, deep endometriosis, people say medical therapy is not suitable, or there are controversy nowadays. I think deep endometriosis is a challenge to all the gynecologists, whether he is a medical specialist or by surgeon. But as it is big endometrium, we discuss that. But the one thing is that sometimes we find acute abdomen following the endometriosis leakage, endometrium leakage, called the leaking endometrioma. Patient's CA135 goes very high, nearly 1000. So that scares us. Maybe we are dealing with a case of malignancy. That is not the case. You see, if there is leakage of endometrium, which sometimes happen, though very rarely, there will be patient will complain of severe pain throughout the whole abdomen, including some diabetic area. Now, fertility enhancing surgery, when associated with T-well factor. If there is T-well block, what do? You have either choice to go for IVF or for surgery. Surgery, of course, there is no guarantee, and IVF also does not give you guarantee to get a baby. For permanent cure, elderly patients more than 45 years, yes, that is the TNFOG of surgery, and when it is demanded by the patient. Sorry. When demanded by the patient, you have to go for surgery. So, in fact, what you sit with the patient, give her the information, give her the diameter of the cyst or the extent of the mapping of the endometriosis scattered in the pelvis. And when you have the choice of treatment, we discuss. Nowadays, we don't take any decision of our own. We discuss everything with the patient, and it is patient preferences. It's less going to a restaurant and you ask for a menu card. If the waiter gives you the menu card, you choose your own food. But you have to ask whether if this food is good, how it tastes, is it a very from yesterday's menu or from today's fresh one, and then you decide which way you want to go. So we have to discuss everything with the patient. It is not our choice. Sorry, where did you go? Now, it is a hard decision to discuss whether you are going to do the surgery or medical therapy. First of all, you have to counsel patient, as I discussed. You have to sit together with the total information available to you, and you have to pass on to the patient's party. The age of the patient is very important. If you are dealing with a patient more than 45 years, And of course, surgery is indicated definitely irrespective of the stage or treatment she achieved in the past. Anatomical distribution is very important as we discussed. If it is associated with rectal endometriosis or deep endometriosis, perhaps it is better to go for surgery. Now, availability scope, yes. Now, this is very important. Whether the approach you are going to do, whether you are going to do the robotic surgery or a simple laparoscopic surgery, depends on the availability of the instruments and scope. Fertility options. If the patient wants to be fertile, remains fertile throughout a period of emissions, then you have to decide which will be best for her. The poor or non-responders means when the IVF fails to give adequate ovulation, you have to think of doing surgery. It all depends on surgical skill, selection bias should not be there, and it is ultimately patient's decision is the best important. The best for the patient. Okay. Now we have to remember what are the most challenging ones. Now I always say there are two types of endometriosis, pelvic endometriosis. One is fibrotic type, and the other one is non-fibrotic type. Fibrotic type is the most difficult ones because the plane of cleavage is very difficult to get. And recurrent and residual disease is always difficult because the patient had encountered many additions all over the places of previous surgery. Associated comorbidity, of course, if the patient had any heart problem or any other comorbidities, that is going to be a challenging one. When there is no boundaries of the endometriosis in the pelvis, I like the abdominal endometriosis associated with pelvic endometriosis, deep infiltrating endometriosis, or die. Now, excelling surgical expertise means early endo and peritoneal endometriosis. More than 4 centimeters. You see, we keep on changing the indication. Previously, the X-ray, they himself committed about 10 years ago that any oma more than 4 centimeters should have surgical removal. Now they are saying it is the second line of therapy. First line is the medical therapy. That is fine. If it is good for the patient, we will definitely follow that dictum. Now, if there is persistent pain, now tell me one oma which does not produce pain. Almost 70% of the patients with oma comes with pain and so if the pain is the persistent pain is the indication, you have to go for surgery. Visual endometriosis like bladder endometriosis or rectal endometriosis, we should go for surgery. But these are the difficult areas you have to review. Cross-tubal pathology. That is a very difficult situation, as I feel, whether you should remove the tube as such, or you still try to conserve the tubes. Or if you want to clip the tubes, I think it is better to remove the tubes. This is your other clipping the tubes for IVF. Thinking back to tube ovulation is a very difficult part. You can do it today, tomorrow you find that they have been back to the pavilion. Again, same additions has come up. Now, this is very important. You should have a multidisciplinary team of references. Means if you think that ureters is involved, you must keep a urologist with you. Or if you think there is a colon is involved, you should keep one colorectal surgeon with you. Now, we also understand surgery, although difficult, it has a higher morbidity, record at 25% within 5 years. That is very. Now, what are the methods of surgical intervention? You can go to laparotomy or laparoscopy. Many will to the patients with better outcome and result. Local excision for scar endometriosis, vaginal part, special. Okay. So you can go for laparotomy, laparoscopy, local excision for scar endometriosis or vaginal wart. Types of surgery can already desiccator, excise, excision or dissection, or drainage of oma, laparoscopic conservative surgery, laparoscopic surgery for dye, fertility enhancing surgery. And of course, lastly, TNFOG or total lateral hysterectomy, plus VSO. Now, choice is yours. I do not think this surgery by laparoscopy is better than open surgery. It all depends on the indication and your which technology you are conversed with. You should go ahead for that. There's no point in doing what I call the touch and go like surgery. We see many patients come with report that they have undergone laparoscopic surgery. But in fact, when you see that they haven't done, the surgeon failed to do anything good for her. I think that's kind of touching that only to us. I wouldn't say extend money, or also give a false impression to the patient that I am a laparoscopic surgeon. But laparoscopic surgeons, whatever you can very well give the same relief of symptoms with open surgery. And there are certain indications why you should go for open surgery or for laparoscopic surgery or even for robotic surgery. Now, why lies the challenge? In completely most of the time, you find cases which are coming as reported as silver disease. It's actually incomplete disease of the tissues. Persistent symptoms, if the symptoms, you must explain to the patient, even at a hysterectomy, there is 5% chance of persistent pain. So hysterectomy is not only can cure the patient, but also it has a risk of 5% chance of persistent pain. Damaging reproductive organs, that is another concern. So you must remember that whether you are attempt to give a relief to the patients and improve the fertility, patient there is a chance of you can make the situation worse by damaging the reproductive tissue organs. Whether your surgery is going to attract more adhesions or not, that depends on that is also there is a possibility. Injury to bowel, bladder, ureter, hemorrhage and infection, and morbidity. Now, we have compared, this is the chart discussed between the laparotomy and laparoscopy. Laparotomy given to every guy, not to every gynecologist. Every gynecologist can perform. All gynecologists, only specially trained ones can do laparoscopy. Restricted visualization, laparotomy. So you have to dig your head into the pouch of globulus to see if there is any involvement of the rectovaginal system or not. Whereas laparoscopy gives you the panoramic view. Laparotomy gives you longer stay in the hospital, whereas laparoscopy is shorter stay. It's painful, less painful, longer postoperative morbidity, quick recovery in laparoscopic surgery. More chance of hernia, less chance. Less expensive, more expensive. Particularly the robotic surgery, which is going to cost about 10 lakhs rupees. Whereas you can finish up laboratory cases by spending not more than 1.5 lakhs, maybe 2 lakhs. Training is easily available for laboratory, whereas less training is there are very little training centers. Yesterday, one doctor from ESI Medical College who was assisting me raised the question whether they can go for training for laparoscopy. It is very unfortunate that the laparoscopic surgery is being taken over by other specialists, whereas gynecologists who invented the laparoscope still lagging behind.
Sir, 2 minutes are left.
2 minutes left. Okay. Indication recurrent diseases, difficult hysterectomy, complicated of 110 diseases. So proper staging is very important. That is why I believe that you have to do laparoscopy in some cases. To consider and explain the benefits and risks of chance of any conversion and recurrence, and then preparation of the patient bowel papers is a must. Send invitation to friends in need. That is very important. So I'll show you some of the clips. This is my open. You see that big endometrioma. People always worry about the destruction of the endometrium tissue. We do also. But still, I think it is very important because surgery gives a better result in terms of recurrence rate is very low. Plus, also it maintains the fertility prospect very well. Yes, we can see that we are also seeing some of the healthy follicles here. But then even then, we are leaving lots of healthy ovarian tissue, which can give us the chance of fertility very well. Usually, we don't use any diathermy. We use only this pull and push method. You can see that you can always remove the tissue very well. Now, the laboratory and laparoscopy was survey treatment of results. It was surveyed in original. You can see that laparoscopy for diagnosis. Additional problem, surgery related additional problem. Here, 3,711 are compared here. You can see the first blue line is the for diagnostic laparoscopy, and the second red line, laparoscopy for removal of endometriosis. And number 3 is the laparotomy for removal of endometriosis. So you can see that all of them have similar complications. Advanced endometriosis and advanced laparoscopies are made for each other. What we have learned, around 45 years, no radical hysterectomy, near radical hysterectomy. So if you are doing hysterectomy, you must always remember that you have to remove all the residual or all the tissues infected with endometriosis. It's a long-term medical therapy or surgery were asked by the case. So for around 45 years, you have choices of 3. As post-medical women diagnosed with endometriosis or therapeutic trial, you can give. Surgery is the indication. No medical therapy except in surgery. This is my appeal, be a member of the NPS. MCQ questions. Thank you.
That was a very, very wonderful session. I would like Pradeep sir to introduce the next speaker.
Before that, I have got quite a few small discussion to Dr. Dasma Patra. PDM sir, are you audible?
Yes, I'm audible. Yes.
I've got very few simple and basic things which often asked to me. I just want your opinion. Number one, how many times one woman should have surgery in the lifetime in endometriosis?
So
Your
how many
opinion.
times?
One woman should have surgery in the lifetime.
Well, that depends. I know, say the lady who formed this World Endometriosis Society, why we brought her here. She had 5 surgeries gone. She had 5 surgeries. So
What
there
is
is
your
no limit.
recommendation?
It depends on the symptoms and the surgeons who dealt with her case.
Okay. Next one, what is your recommendation regarding post-operative medical therapy? If so, how long?
It all depends. If the patient is trying for a baby, we do not give any medical therapy post-operatively. If the patient is not trying for an operation or infertility treatment, then we give
Yeah.
her post-operative therapy because that might prevent the recurrence, or even if it occurs, it will come very late.
Good. And lastly, you have just shown a case of ovarian endometrioma and other things. Now, regarding endometrioma, although this excision of the endometriosis cyst is usually been recommended, but often, sometimes it is not possible. And some young surgeons or new surgeons, they go for this ablation of the endometrioma. Now they ask me how to know the correct extent of ablation while doing laser or argon or other things or electrodynamic, etc. How to know when to stop this ablation while doing endometrioma ablation?
Ablation without cystectomy, you mean?
Ablation of ovarian cyst,
All this
endometrium.
Okay. Well,
Because
it all
most of the
depends
time,
on the
most of the time it is being overdone and ovarian reserve is being destroyed, lost. So there is, what is your opinion?
I think first of all, we should not do any ablation of the ovarian cyst. If you do, always you ablate towards the ligament of ovary, through which the blood supply is coming. If you ablate that area, then you are causing or more dangerous situation. Means the ovaries may atrophy. So it is better to ablate far away from that area, corner of the uterus, and you ablate towards the periphery of the cyst wall. But what will be depth, I do not know. I cannot give you any report on this.
Yeah, thank you very much. That is a great input for young surgeons or newly, because they often overdo and they often don't know that only this pigmented area, this dark colored layer is to be ablated, not the deeper tissue. As soon as this yellowish area is being found, this ablation should be stopped. That is the main thing. Thank you, Dr. Mahapatra, for excellent deliberation, and you have highlighted the multidisciplinary management and indication. And now I would request my co-chairperson Ujjal to introduce the next speaker. Ujjal, go ahead.
Thank you very much, sir. Thank you. Thanks a lot, sir. It's indeed a great honor to introduce our next speaker, Dr. K.U. Kunjimuddin. He's an MD and DNB of ICOG with 28 years, illustrious years of experience in the field of reproductive medicine and gynecology endoscopic surgery. He's a president of Kerala Federation of OBG 2024, a medical director, Birla Fertility ARMC IVF, academic director of Birla Institute of Fertility Sciences, senior consultant, Birla Fertility ARMC Calicut and Perinatamalan, Kerala. Is a former chairperson of ISAR Kerala Chapter 2022-24, as well as the founder and the president of Perinatham Malana ONG Society 2020 to 2022. Is a champion of ISR Award, ISR Dronacharya Award 2024, organizing chairperson of YUVA ISR 2016 and 2023, so pretty recent. Fertivision 2018, Gesticon 2024 and 2025. He's a candidate of FOGSI Infertility Committee chairperson in 2026. So welcome aboard, Dr. Kunji Mohiuddin. The floor is all yours, sir.
Yeah. Hi, good evening all. Thank you for the opportunity, respected President Endometriosis Society of India, Dr. Das Mahapatra, the Secretary, Dr. Pradeep Kumar Mitra, the Scientific Chairperson, Dr. Ramani Devi, and the President of TNFOG, Dr. Vidya, and Secretary, Dr. Sampath Kumari. And at the outset, I thank Dr. Ramani Devi for giving me this opportunity. Let me share my screen. So the topic assigned to me is the newer techniques in endometrioma management. A lot of things have been discussed by the previous professor with regard to the endometrioma management, in how to do in pain with endometriosis, what to do in endometriosis with infertility. And the paradigms with regard to the management of endometrioma is keeping on changing as the newer technologies and newer techniques have been recommended and some of the newer concepts have been introduced. When we started our practice way back almost 30 years back, that time we used to do laparoscopy for almost all cases of endometriosis. But when the ART practice has come into in a big way, so we thought of doing the recommendations or even NSHA recommendations are not in favor of doing surgery for endometrioma patients with severe infertility or associated male factor when the ovarian is compromised. Only in some specific situations we are recommended to do the surgery. So why the management strategy that matters? Because endometriosis that contributes almost 17 to 44% of women with endometriosis and seen in 20 to 40% of infertile women. So a large proportion of endometriosis patients will have endometriomas. And this is associated with reduced ovarian reserve, poor follicular response. That is a very big challenge for the IVF clinicians. Even if endometrioma is not being operated and when we are starting stimulating the patient may not respond as we expect, corresponding to their AFC and AMH. And there is increased surgical morbidity for this group of patients with endometriomas. And surgical decisions that significantly influence the AMH decline and the IVF outcomes. So how you do surgery and what patient you are doing surgery, these are very important determinants or denominators of the reproductive outcome of these patients. So what should be the goal? Treat the disease while preserving the ovarian tissues. And the classical cystectomy, this is a laparoscopic cystectomy. There are a lot of things we need to take care while during the cystectomy. Even though laparoscopic cystectomy, that remains the gold standard. Is it without any compromise? Of course, it is. There is a compromise of around AMH reduction, 30 to 50% after bilateral cystectomy, however careful we do. So the healthy ovarian follicles that may disappear from these things, and ultimately AMH can come down, and that can even affect the reproductive outcome of the patients. So there are a lot of things we can do to reduce the compromise in this ovarian reserve for these patients. And initially, when dissecting this endometriomas, do it very carefully without damaging the underlying structures and reduce the bleeding from while during the endometrioma cyst wall excision by using vasopressin, and avoid cystectomy at the hilum because cauterizing at the hilum, it can create a lot of bleeding even if we use vasopressin. So that point, to avoid the coagulation at that point, avoid cystectomy at this point, which is very important, and not to excise the healthy ovarian tissue. And the first surgery is the best surgery. Earlier, the chairperson asked how many times of we can do surgery. Better not to do surgery as many number of times, reduce the number of surgeries, and repeated surgery that always increases the risk of premature ovarian insufficiency. And the repeat surgeries, there will be a lot of adhesions, and it can create the possibility of injuries to the adjacent viscera. That also is possible. And second thing, while peeling out the ovarian tissue, should peel out the tissue very carefully, because ovarian tissue, even a healthy tissue, you can peel out in layers. So while peeling out, see it, make sure that it is in the right plane. So what is the paradigm shift which I have mentioned? Modern surgery that emphasizes the tissue sparing techniques shift from complete stripping to controlled ablation. So that is the shift now which is happening. Reduce cortical damage and preserve follicles, and important in IVF candidates and bilateral disease, and focus on fertility preservation, which is very important irrespective of the number of children they have. So what are the newer techniques which is coming into practice? One is carbon dioxide laser vaporization and plasma energy ablation, combination of stripping plus ablation approaches, ethanol sclerotherapy and three-step technique, robotic and ultrasound guided techniques, selection based on fertility goals and ovarian reserve. So what do you mean by carbon dioxide laser vaporization? The concept is focused laser energy that vaporizes the cyst lining. So the cyst has to be vaporized only at the areas, mainly preferably the cauterization or ablation should be done in the active areas. These areas will be a little bit reddish or blackish color. That area has to be vaporized, and precise targeting with minimal thermal spread, and the penetration spread of the laser vaporization is maximum 0.2 millimeter. So that will save a lot of the underlying ovarian tissue and preserves ovarian cortex and follicles, which is very useful in fertility preserving surgeries. So this is one of the laser vaporization. So it is comparable pregnancy rates and better ovarian preservation, lower thermal damage, useful in bilateral and low reserve cases, because sometimes the ovarian reserve will be low when before we are stimulating the patient will be having severe pain, or the follicles may not be approachable. So in such cases, irrespective of the reserve, we may have to opt for surgery. These patients are ideally suited for ablations. And plasma energy ablation, that's a major advanced ionized gas plasma for superficial ablation. Minimal lateral thermal spread, which is very effective for preserving the ovarian tissue as well as the adjacent tissues like ureter, and preserves ovarian cortex, useful in recurrent and bilateral disease and comparable symptom relief. So plasma energy versus conventional cystectomy. So the AMH decline is much lower in these plasma or laser ablations if it is being done properly, and comparable pregnancy rates, slightly higher recurrence because we are not stripping down the cyst tissue, and useful in fertility focused patients and requires an experienced surgeon as well as the technology. And what is the three-step technique concept? That is one of the most important thing in these patients. Minimizes the ovarian tissue loss, useful in large or bilateral cyst, improves surgical precision, and reduces the vascularity, and used in fertility focused patients. So what are these three steps? Drainage and biopsy, that is the first step. Then give GnRH agonist for 2 to 3 months. Then second surgery for the removal of the cyst and reduced vascularity that aids the preservation of the ovarian tissue. And that is the ultimate three-step technique. There is something like combined stripping plus ablation, partial cystectomy, and ablate in the most dangerous areas, reduces the cortical damage at the hilum, useful in dense adhesions and preserve ovarian tissue, and it is one of the fertility focused approach. So there is something like sclerotherapy. So it has been there for a long time before, and it is coming back in a big way later on. Minimally invasive, it can be USG needle guided as well as USG catheter guided as well in some of the situations, and ethanol instillation. So it will be installed after aspirating the cyst. Ethanol will be 95% ethanol will be instilled for 10 to 15 ml. That will be, we allowed that to stay for 15 minutes. And this seems to destroy and remove the ethanol later on. And this seems to destroy the cyst lining and useful for IVF patients. You can see on one side, it is post sclerotherapy image. Though outcomes minimally invasive, useful before IVF, acceptable recurrence control, and risk of recurrence is there because the cyst wall is not removed. Careful selection is important. What is organ beam coagulation? That is something, another way of coagulating. It is useful for superficial coagulation. Controlled thermal spread, much better than the laser and this plasma, and useful for residual capsule, reduces the bleeding, but the evidence is just coming up. Robotic surgery, because that is something which is very good in severe endometriosis, deep infiltrating endometriosis, where because of the anatomy or because of our hands limitation, if the instruments cannot reach, robotic will help to a great extent to improve the precision, useful in very complex cases to improve the visualization, but the cost is a limiting factor. So the ultrasound guided techniques already I described, aspiration and sclerotherapy, which is useful before IVF, minimally invasive, improves follicle access, because that is one of the indication before doing this sort of interventions before stimulating the patient for IVF. So affects oocyte yield and access. So always better to consider for interventions in any sort of forms as per the availability of the technology and expertise. Avoid routine surgery for small cysts. Operate if pain or malignancy suspicion. Don't ever ignore about the possibility of malignancies in recurrent endometriomas. That is very much possible. And IVF first strategy, that is the most important to have the reproductive outcome. So what are the recurrence rate? Cystectomy, if you do it properly, that is having the lowest recurrence. Ablation, moderate recurrence. Higher recurrence in bilateral disease, and suppression reduces the recurrence. Long-term follow-up is very much important. Ovarian reserve impact. Cystectomy reduces the AMH, I told 30 to 45%. Ablation to some extent reduces the impact, and plasma still less AFC reduction. Laser has minimal damage. Only tissue preservation should be the priority in all techniques. So coming to the fertility outcomes, all these as newer technologies have similar comparable pregnancy outcomes like our traditional conservative cystectomy, and IVF not improved by surgery. So the outcome of IVF or the result of IVF will not be improved even if you are doing a cystectomy in a non-indicated patients except for pain or access, and depends on reserve and severity. And surgery for always symptoms, that means severe pain, mostly it will be due to deep infiltrating pain or associated adenomyosis. So individualization is the key. So bilateral or recurrent cases, low ovarian reserve, ablation preferred in fertility cases, cystectomy for malignancy suspicion, individualization. So decision algorithm to summarize: assess the size and symptoms, small cyst with infertility, IVF first, and large symptomatic, then only intervention by anyways. Low reserve, ablation is the preferred key, and recurrent conservative approach. So all these are emerging techniques: AI-assisted, image-guided precision, robotic refinement, regenerative technologies, and future fertility preservation. So the practical tips: avoid routine surgery before IVF, preserve the ovarian cortex. So even if you are doing cystectomy, just spare the hilum and use tissue sparing methods, use vasopressin, have proper situations to control the bleeding. IVF first in selected cases, and surgeons expertise always. So to summarize, before the allotted time, the cystectomy effective but reduces the reserve. Tissue sparing techniques preferred, and laser and plasma key advances. IVF first strategy, that is the growing evidence, and patient selection and individualization is critical. Before winding up, I request all of you to support me for the chairperson infertility committee, folks. Thank you for the patient here.
Thank you. Thank you very much for your excellent deliberation, most promising deliberation, particularly in relation to fertility conservation. You have highlighted the two areas I must appreciate. One is this sclerotherapy. Yes, this is the old wine in new bottle.
Yes.
Long before, I used to do it with 5% tetracycline, long back, say about 20, 25, 30 years back. And it used to give a very good result, and now ethanol is being used. And you have highlighted the plasma therapy, and that is so important, and are going to be. Now, I have got one question and two comments. One, do you use vasopressin or saline while doing cystectomy to separate or to get into the plane of ovarian cyst and the wall?
Yeah, so I use 20 units vasopressin diluted in 100 ml saline. The first injection I'll give to the near the cornwall end of the uterus towards the posterior wall of the uterus, so that we will have almost near bloodless dissection from the ovarian fossa. That is where the dangerous bleeding sometimes happen. And second thing, before cystectomy, I do the same diluted vasopressin to the ovarian tissue. But most often, if the injection which is given to the uterus has made that area vascular, I prefer to give saline because saline is the most safest.
Do you ever use ICG for ureteric identification or anything?
No, sir. I never used to use, but internal this illuminating ureteric catheter sometimes we put for the recurrent surgeries so that we can sometimes we switch off the light and see whether that it is illuminating the ureter. That's what actually I practice.
Thank you. I've got two things to mention about these new areas. One is photodynamic therapy. Photodynamic therapy is coming up as a new area of this conservative type of surgery. Apart from that, tissue engineering, as they've highlighted, and
Yes.
last but not the least, is stem cell therapy.
Yes.
Stem cell therapy, Mehta is doing this menstrual stem cell injection to the endometrioma, and
Yeah.
he is getting good result. Although these are all at the experimental stage. Thank you very much for excellent delivery.
Thank
Now, let me pass on to the next speaker. Can you show me the? Yeah. Now it is Ruma, Dr. Ruma Sinha. She also needs some introduction. She is our deputy secretary of our society and is a very hardworking lady and doing a lot of work in this robotic assisted surgery for endometriosis. I am not going into the details of her biodata, and straight away I want to hear from Ruma. Ruma, go ahead with your presentation.
Thank you, Dr. Pradeep Da. Am I audible?
Yeah.
Okay. So, hello to everybody. Namaste, PDM sir, Abhivinesh, Pallavi, Ramani Devi ma'am. I think it's a really honor for me to be requested to participate in this very important CME. I was listening to this talk before me with a lot of interest, and I think a little bit of talk about using robotic surgery for endometriosis and endometrioma did come up. So let me, without wasting time, let me share my slides and we'll talk about it. So is my slide visible? Sorry.
Yes, ma'am. Just
Yes,
let
ma'am.
it full screen.
It's visible? Okay.
Yeah, you just want to go to slideshow mode, ma'am.
I'm just going there, Is this good?
Yeah, ma'am. Absolutely.
Okay, so I will take a little bit overview about how robotics is being used for endometriosis and then go into the details of about how in deep infiltrating endometriosis. So coming straight to the topic, let me just show that the setup for what we do in endometriosis with robotic or with laparoscopy actually remains the same. So we always use a manipulator, because we know in endometriosis going into the posterior fornix is very important to make sure the uterus is pushed in and anteverted. We can use various other techniques to do the same, but I prefer to use a manipulator because many of these patients are also fertility enhancing surgeries. So this particular manipulator that I use has an extra channel to which, without removing or putting anything else, I can use another channel to actually do tubal perturbation as well, because that will be an important part of my reproductive enhancing surgery to free the tubes so that they are functional and give that information to the patient in the end. The ports that we put are very similar. Again, I don't do any different port placement when I do robotic surgery. If you look at the left side of the patient, my optic port is at the umbilicus. 2 ports on the left side. It is very similar to how we put in laparoscopy. And if you see, there are, of course, reusable 8 mm ports that we use in robotic surgery. These are Apple trocas of 5 mm for my assistance. Normally, when I do robotic surgery for other things, I don't use an extra 5 mm, but I do use this extra port, which could be a 5 mm assistant port who can actually do some assistance or hold my bowel or something like that. Or I can actually use this as another 8 mm port, which will then come as a third arm when I'm doing my robotic surgery. So this is for people who actually still are trying to understand how we do robotic surgery. That is the patient cart. This is the so-called robot, which then can move after we put those ports. And this is the laser pointer, which actually gives me where exactly that patient cart should be placed. This convergence of the two lines is at the optic port, which is where we will then place the robot. Once this patient cart is docked, then we dock the first port, which is the optic port. When we dock the optic port, we put the camera in. Now you can see this is the arm through which the camera gets docked. The camera goes in, the telescope goes in, and then we do what we call as targeting. So you can see in endometriosis patients, you can find a lot of adhesions to begin with. So this is called targeting. When we do targeting, the boom automatically moves so that it comes to a right point where my other instruments will go in and out easily so that they don't unnecessarily clash. So this is an important part of starting the surgery. So we use the laser beam, get the right port, then do the targeting. And once this is done, then we dock the other ports. This is the master, which is there at the console level, which is used to manipulate the instruments. So that's how we actually use the masters to manipulate the instruments sitting on the console. And you can see the view of the OT after this is actually, these are the foot pedals that we use. Comfortably sitting, ergonomics is good. This is how you use the masters, move the instruments, and then you can see you are a little far away from the patient, but not very far away. And that's where the patient is. These are all my assistants, and you can see most of them are standing like this because we have the arms under the patient with the robot. Nobody needs to do any manipulation at that point, and all the manipulation that is happening through those masters that I have at the console. So after understanding how robotics is being used, why in endometriosis and why do we need to discuss? If you understand deep infiltrating endometriosis is behind the scenes. What you see at the surface is just tip of the iceberg. And when you start excising, you begin to appreciate the depth of this disease, often engulfed in fibrosis, inflammation. And when you start dissecting, it may look a point, but you start dissecting, you'll find you have actually dissected almost a 1 centimeter, 2 centimeter diameter peritoneum at that point of time. So it's a complex surgery in gynecology because the retracted tissues retract because of fibrosis. We have to operate in deep pelvic spaces. And of course, ureterolysis becomes a very, very important part. And that's done by us almost in every case. Whether the case is simple or difficult, we always start with ureterolysis at the pelvic brim. You need special skills because dissecting in deep retroperitoneal space is tricky. Isolating the ureter, as I said, and also the bowel from the posterior compartment. And of course, you will need suturing techniques to be mastered to be able to do that if that is needed. So extensive pelvic dissection of the side walls, uterosacral ligaments, the retrovaginal septum, ureterolysis, as I mentioned, and then go ahead and excise the nodules or rectal excision or whatever you need to do. So robotic surgery for deep endometriosis, a paradigm shift was published not now, but almost 15 years back, 2013, where they talked about that it could actually help in precise and better surgery. But we also had some people talking not so in favor of robotic surgery. And this is a very famous song, area supply called Money for Nothing. The role of robotic assisted surgery for treatment of endometriosis is just money, or do we actually, this was a very, very thought-provoking article by Nicola Bernarda. But from that point of time, many articles have come out, many scientific publications have come out, of which I will also share one of ours, which actually points out the benefit. These are some of the initial articles that we published. So lack of haptic feedback, and that is the most important discussion that happens against robot in treating endometriosis effectively. So with 1 decade, more than a decade now of experience with me, if you'll see, is the visual haptics that start working. This little video actually is trying to demonstrate how you get into the right plane on the right and left side. You dissect the rectum down, both the ovaries have been freed. And this visual haptics doesn't require that you need to know how much tissue or tension you are applying, but the visual haptics and a very effective use of monopolar dissection actually lets you get into the right planes. Healthy tissue versus fat will be usually fatty and moist, and the fibrotic tissue will be hard and dry. And that is something which vision can very well help you to understand and how to go about it. This is a Larcos trial, a multicentric randomized trial, where they mentioned that mean operative time, blood loss, perioperative outcome conversions were same in laparoscopy and robotic. So the first thing to understand is robotic surgery is not inferior to laparoscopic. And many of us are very experienced in laparoscopic surgery. But can robotics actually impact the surgical management in endometriosis? We must remember, robot is just a surgical tool. It can overcome your kinematic limitations of a conventional laparoscopy. Movements become more intuitive because you have two instruments coming from both the side, midline of the pelvis. They have wristed movements. You get near control of the surgical field because you are moving the camera, you are moving the instruments, you have one more instrument in your control. It also does tremor filtration, and I believe me, over 15 years of doing robotic surgery, this is one thing that in endometriosis I love. Because when I'm very close to the ureter with dense fibrotic tissue, I have to dissect the ureter and get it off my field. When there is tremor filtration, I know exactly where my monopolar current will hit. It will not hit even a millimeter or to the side where I intend it to. If when we are doing laparoscopy, that's one of the concerns, because at the end of a large hook, spatula, or a scissor that you are using monopolar to dissect, there is always a little tremor whether you like it or you don't. Even skilled surgeons, less skilled surgeons have less conversions in robotic surgery. And of course, there is a shorter learning curve. But the technology you use impresses no one. It's the experience that you create with it is everything. So the experience for yourself as well for the patient. This technology cannot compensate for lack of surgical judgment, lack of skill, or deficient knowledge of anatomy and pathology. But this is another one very interesting article which I came through, is the singer and not the song. When we talk about endometriotic surgery, it is the person who is doing the surgery. Pathology will be complex. Almost all endometriosis pathology is complex. So the ultimate clinical outcome, pathology is same, how one approaches, how one does. And this is by a very, very important pathologist, actually, Munzi, who has published a lot of articles trying to tell how much ovarian tissue is getting lost when we do endometrioma. So what are the procedures you can perform? As I said, ureterolysis is one of the most important procedures that we do almost always. This is on the right side, right at the pelvic brim. And you can see the dissection of the ureter is very, very precise. I'm right at the ureter, but I know exactly where my monopolar current will hit. And so I'm able to dissect the ureter quite well. This patient has a right uterosacral nodule. I'm dissecting the ureter from the pelvic brim, lateralizing it, making sure we have adequate distance between the ureter and the nodule for me to excise it precisely. So you can see now I'm dissecting, a part of rectum is getting pulled up here. That's the uterosacral nodule, a big nodule, and that's the ureter which is there. So that's the uterosacral nodule I'm trying to excise. And this is where my precision with robotic actually helps. So once I know that's the ureter, I'm constantly lateralizing it, you can see, very, very close. I'm dissecting the peritoneum with much more confidence that I ever did in my laparoscopy or ever do. I still do laparoscopy. And sometimes when I do laparoscopy for deep infiltrating endometriosis, I always say, why did I get into this theater? I should have done it with the robot. And that's the benefit you have with robotic surgery. So I'm just trying to give you a glimpse of one surgery where we are actually getting into the you can see that whole thing is a thickened uterosacral nodule. The whole thing has to come out. And that's where the ureter is. I know I'm more than 1 centimeter away from the ureter. So I can very, very precisely and confidently remove this nodule with precision. Butterfly peritonectomy is one of the surgeries which was propagated by Dr. Patel. And this comes in very useful if you have multiple patches on the peritoneum around it. So in this particular patient, you can see we are removing one from the pelvic brim almost, dissecting the left ureter, lifting both the ovaries away because you need the peritoneum free to be able to do that. Again, I start by the left side. You can see again there is a ureter right there. The ureter is moving, and I don't like putting a stent in the ureter ever because I like a moving ureter because that gives me the most confidence the ureter is working. And you can see it very beautifully while you are doing this dissection with robot because you have a 3D stereoscopic vision. You feel as if you are into the pelvis trying to dissect what you are dissecting actually. So now you can see there is enough lot of peritoneal nodules all around in the posterior fornix. We dissect them precisely, layer by layer, and not anything more than what is needed. So you can see once this is dissected, the fibrotic tissue is in my hand, but the smooth tissue which is moist, and full of fat is actually the right tissue which needs to be left behind. So after doing the left side, now we come to the right side. Again, the right ureter is moving in my view. So I know where exactly it is. And that's where we go ahead and remove the whole peritoneum from the posterior fornix. So that's now the right wing of the butterfly, as we call it. Once this is there, that's the left wing of butterfly. And that what we showed you was the body of the butterfly. So this is the whole thing that we can remove from the posterior peritoneum, strip it completely to improve the fertility outcome as well as pain scores in patients. Now, we also do cystectomy in endometriosis, and we have a different technique of doing endometriotic cystectomy. So in laparoscopy or any other conventional teaching is you hold the ovarian tissue, you hold the cyst, and you just, of course, get into the right plane and then just pull it apart. But in robotic surgery, initially when I started doing, I realized that was not needed because I had a very good vision and a good plane. So I would actually use a very short burst of monopolar current and keep getting into the right plane and dissecting. Why I wanted to do this? Because I felt that you don't leave a very weeping ovarian tissue behind. So you don't have to use a lot of bipolar current at the end of your procedure. Doing this for a few years, I felt, okay, I'm trying to do a different technique. Am I doing correct or wrong? Anecdotally, I felt this was a better technique because I felt we could remove the cyst wall precisely. So we actually did a kind of surgery comparison between laparoscopic and robotic surgery in pathology using an artificial intelligence pathology. I don't know where that, okay, that's not there. Okay, so we used artificial intelligence pathology. The pathologist was blinded. They didn't know whether the cyst wall was coming out of a laparoscopic cystectomy or a robotic cystectomy. And we compared our results for two things. One, the amount of ovarian tissue that came out in the cyst specimen and the number of follicles that came out in the cyst specimen. And we found that in this research that the cyst which was more than 6 centimeters, and in bilateral disease, the amount of cyst wall and the amount of follicles lost in robotic cystectomy was significantly lower. And this has actually become a landmark paper, which we can now think, especially in patients of infertility, that if we have to do an ovarian cystectomy, probably a robotic cystectomy will be a better idea. If you have bilateral cystectomy like this, you have kissing ovaries. Again, the step one is to separate both the ovaries clearly. Once we do that, we have the posterior fornix in our view, and we know how much of rectum adhesion is there. If not much, then all we need to do is clear the robotic cystectomy. But again, we need to actually identify the ureter, which we, as I said, we always do. This patient had a large cyst sitting at the pelvic brim. So there was a distension of the ureter above it. Once we release the cyst, did the cystectomy, we have not done any ureteric reimplantation or anything for this patient. We put the stent for 6 weeks. We are in follow-up of this patient, and this patient has absolutely normal ureter once the pressure of the cyst. So bilateral cystectomy was done in this particular patient. So excellence through teamwork. Now, deep infiltrating endometriosis always has neighboring organs involved, like bladder, bowel, ureter, or whatever. So we need to multiply our clinical outcome by doing a good teamwork. So again, same situation of ureterolysis, but this is another one where if you see, while I was doing a hysterectomy, this is an adhesion of the rectum into the posterior wall of the uterus with a foam. Now, in this particular situation, we always feel that it's important to leave the nodule on the rectum to begin with, then trying to reach a layer where there will be actually dissection of the rectum. So once we do that and we separate, then we go ahead and shave the rectum off of the nodule so that it becomes easier. So this was a hysterectomy. So we didn't mind if we left a little bit of endometriosis on the uterine wall because we had to remove the uterus ultimately. But then we went ahead and shaved off the rectal nodule from the rectum at this point. So this is another way of approaching rather than going into this plane with the attached to the uterus. This is a much easier because you can hold the rectal nodule very well, identify the plane, use very sharp cutting monopolar current, and go ahead and dissect this nodule off the rectum. Deep infiltrating sometimes robotic assisted dissection can be any dissection can be very difficult. Again, understanding the anatomy, going into the both medial pararectal space, the so-called Okabayashi space, is very important because unless we free the rectum, we can't drop it from the rectovaginal septum. So this is the right Okabayashi space. You can see dissecting the rectum off the uterosacral nodule, clearly getting into the right Okabayashi space. Once that happens, then we will go to the left side and then drop the rectum from the rectovaginal septum. So that is the right Okabayashi space. We come to the left side, that's the left ureter on the left to the space that we are creating, and then we are opening the rectovaginal septum and dropping the rectum down. So this needs a systematic approach. Just straight away we go into the rectum and start dropping it, it won't, we will get into trouble and we may have more injury. Sometimes we can have a large, that's the dilated ureter, a large nodule in the parametrium, which is infiltrating also the vaginal mucosa. So these are situations of deep infiltrating endometriosis. We have already done our dissection. The ureter has been lateralized, but still ureter is in my view as I'm operating and dissecting this large nodule from the left parametrium. Now, once we start dissecting, we realize that there are multiple cysts of collected blood there, and we will slowly go into enter the vaginal cavity and then remove the whole parametrial nodule along with the vaginal mucosa. So this is the nodule that we are tackling. So you can see every time I'm trying to make a incision, I have to redefine my boundary to make sure the whole thing comes out. But we have to be careful that not go extensive, because we have a ureter here. We can't really go too lateral here. So we need to slowly get into this plane, keep dissecting, and ultimately we reach the vaginal mucosa. So that's the vaginal canal that gets opened. We remove the
I think ma'am's internet is down. I think
Yeah,
it's-
I think the network dropped. Yes.
Is there any technical problem, Ruma?
Ma'am is
So I'll just
disconnected.
call ma'am and I'll confirm, sir.
Yeah, please.
So in the meantime, shall I start my presentation?
Well,
I'm sorry,
yes.
am I audible now?
No, yeah.
Yeah, I'm sorry. I think there was some disruption in the electricity for a minute. I've just gone onto my hotspot. So, okay, so we will just a few more slides, and this we are talking about tailored radical hysterectomy. So in radical hysterectomy in deep infiltrating endometriosis, we have a different thought process in which we talk about en bloc dissection. And en bloc dissection actually goes where we go laterally from the side. This was one case where, if you can, when we entered, there was just even fundus of the uterus is not visible. That's the rectosigmoid adhesion behind, and that's the bladder pulled up. This patient had deep infiltrating endometriosis along with a large fibroid uterus. So these can be very, very difficult situations where good precision, good visibility can actually help us. I think maybe we are short of time, so I will just show you some other small applications of robotic surgery. This is an anterior compartment disease where, as I told you, it looks like a small nodule or a small speck, but when you actually start dissecting, it's much deep, and the amount of peritoneum that you have to dissect is very high. Sometimes you may have completely soft, small bowel completely having a lot of vesicular endometriotic involvement. Or you can have foam or focal adenomatic of outer myometrium, adenomatic lesions, which you need to actually again excise, dissect, and remove. So all these situations can be very well handled. What does my data show? We talk about that when we do Da Vinci or robotic surgery, the patients that we pick up are of high BMI. Actually, the duration is much less. Blood loss is less, transfusion is almost nil, and concomitant procedures that we are able to do are much higher when we do robotic surgery. These are some of the data between using the earlier version and the newer version of what we are trying to do with robotic surgery. So I'll end my talk here. We'll leave it for audience to ask some questions. Benefit to me as a surgeon, as I said, Kramer infiltration, intuitive movements, and I did not need to unlearn my laparoscopy. I still continue to do my laparoscopy because when I enter my robotic surgery theater, probably my right side of brain works, and when I get into laparoscopy, some left side brain works or whatever. You actually integrate a lot of information, a lot of skill that you've learned in laparoscopy to actually utilize robotic surgery. So robotic surgery for endometriosis has similar outcomes as experienced conventional laparoscopic surgeons. Cost of robotic surgery is the limit, and its availability. Long-term prospective randomized trials probably is needed, and it can facilitate the spread of minimal access surgery. So a lot of surgeons who are talking about from cell to surgery on fibroid uterus. So thank you very much. I really appreciate the time that was given to me.
For the first time ever, we introduced.
Thank you.
I can
Thank you
stop.
so much for excellent deliberation, as you do always. And I do believe that definitely in future robotics will come up in a great way, and the cost will decrease and the expertise will increase. You have highlighted particular important points which I also appreciate. One is precision of the tissues. Second one is absence of tremor. That's so important with aging, which we do have in our life. And then ergonomics. That is very important. And last but not the least is the use of monopolar that you have shown. That is also very important. I also appreciate the very important point that while doing DIE surgery, the bilateral lower eupexy, fixation of the ovary, temporary fixation of the ovaries to the abdominal wall is so important. They have also shown the peritoneal resection, which I also do believe is so important for prevention of recurrence. But I've got one or two simple questions for you. Can you just tell me what is meant by deep infiltrating endometriosis or DIE? Because there's so many things, so many.
I know, sir.
Your view.
I know, sir. So actually, when you define the definition of deep infiltrated endometriosis is any endometriosis which is more than 5 millimeters of depth. But today, I think deep infiltrating endometriosis is being used a lot in a colloquial language. And everybody, yes, so everybody, whatever the endometriosis may be, is DIE today, which is not true. That's one thing. Every DIE does not need as extensive surgery as happening. So deep infiltrating endometriosis, by definition, if the depth is more than 5 millimeter, that's how we define it as a deep infiltrating endometriosis.
Progressive and underneath the peritoneum, then it's called deep DIE. So that is changing trends, the defining how it is to be done for deep infiltration. And secondly, what preoperative assessment and staging you do? Just in few lines to say.
I didn't get your question, sir.
What preoperative assessment or staging you do before going to robotic assisted?
Got it. So it is 3 steps, sir. Number 1 is a detailed history. And that history, I normally say as anamnesis. That means the patient is given 5 to 10 minutes to just talk about herself, not the present problem, but coming back from menarche, how things moved. So detailed history is very important. And in this detailed history, just dysmenorrhea and heavy menstrual bleeding does not suffice. We need to take a lot of vegetative symptoms, as we call as bloating, difficult, maybe menstrual headache, nausea, vomiting, defecatory pain, voiding pain, dyspareunia. So all these detailed history has to be taken. The second is, I feel is very important, is my digital examination, both vaginal and per rectum. Because that gives me the most important information, even more than what my imaging can give me. And then that digital examination, I correlate. I am a big MRI fan, and I read my MRIs myself. So I get MRI for each patient if I have to intervene, and get the CD and read it myself. So this history with my digital exam with MRI is my correlation. After this, I then look into what is the patient's desire and need. So the patient has to tell me whether they have come to me for pain relief, for fertility, or both. And then I will point wise tell initially in counseling to the patient that this we will find, and this we are going to do. So make sure that her expectation from surgery is absolutely correct. Otherwise, patients come to surgery thinking everything will be over and surgery, I'm done with it. So we have to counsel a lot of things by these three things that I conglomerate and tell the patient that, one surgery is not enough. This is what will happen. If I'm doing fertility enhancing, maybe pain will not go completely, but we will look into fertility. So a lot of these, it's not that simple in a patient of endometriosis.
That's the reason I asked you this question. Thank you. Thank you very much.
Thank you, sir.
Thank you very much. Ujjwal, you go ahead with the next speaker, our Avinivesh. Introduce our Avinivesh. Dr. Ujjwal, are you here?
Yes, sir, I'm audible. Yeah. You're audible, and I think I'm audible as well. It's indeed a great honor to introduce our next speaker, Dr. Abhinivesh Chatterjee. And I happen to discover that we are essentially colleagues across the oceans. I've been associated with the Manipal group since last 23 years. And so is Dr. Abhinivesh Chatterjee as well, consultant at Manipal Hospital, erstwhile Columbia, Asia.
We are running short of time, so I think we start with the presentation.
Yes, sir. I particularly wanted to highlight one important fact about the Limca record that you hold. So, very exciting time, and please go ahead, sir.
Thank you. So my screen has been shared now?
Yes, sir.
Yeah. Thank you very much, PDM sir, PKM sir, and also Ramani Devi for this opportunity. I am speaking on a subject which is very close to my heart, recurrent endometriosis. So endometriosis is notorious for recurrence, and all studies have shown that even in best of hands, if you do the surgery, there is a recurrence rate of 35%. So he who knows endometriosis knows gynecology. This is what Professor William Osler told. And to me, I think this is the same thing, which I think. Now, it is a clinical entity characterized by presence of tissue, for endometrium tissue outside the uterine cavity, and bit of history dates back to 1600 BC, and it's a disease which has been associated with high estrogen level and low progesterone receptors. Now, in recurrent endometriosis, what we encounter is adhesion. That is the main thing. And as gynecologists, once we trained, we were told to be push the bladder down, don't touch the ureter, don't touch the rectum. And this is how we got trained. But endometriosis is a surgery where you cannot just avoid touching the ureter or the rectum or the bladder. So it is a complex surgery, especially in recurrent endometriosis, and mentally one should be prepared to do the adhesiolysis. That is very important. And to me, the epicenter of endometriosis, once we started laparoscopic surgery, was the ovaries. We could see a lot of ovarian chocolate cysts then. But now the epicenter has shifted to the uterosacrals. So one should be prepared that the uterosacrals will be involved. And once the uterosacrals are involved, they are in close vicinity of the anterior rectum and bilateral ureters. So we have to do the mental homework that we want to take care of the uterosacral, lateralize the ureter and the anterior rectum. We should drop it down. So if we follow a stepwise mathematical rule in endometriotic surgery in every patient, then things become easier. First, start with the left sigmoid mobilization, then bilateral ureteric dissection up to the ureteric tunnel or the uterosacral ligament. If you are doing a laparoscopic hysterectomy, devascularization of the uterus by opening the lateral pelvic wall and opening the pararectal and paravesical spaces and coagulating and cutting the bilateral uterine arteries at the origin. Remove bilateral adnexa, otherwise they tend to hang, obscuring the view of the Okabayashi space or the pararectal space. Or you can use your T-lift to attach the ovaries to the anterior abdominal wall. Opening the bilateral Okabayashi space, this is the space between the uterosacral and rectum. All my junior colleagues feel that the entire structure there is rectum. That is not true. There is always a space between the uterosacral and the rectum. Dissect up to the levator ani laterally, then introduce the rectal probe and dissect in the fat plane lateral to central. So either you use a rectal probe or you pull the rectum to find exactly the limits anteriorly and laterally. It's very important to delineate the limits laterally, otherwise there will be chances of injuring the rectum. Use cold scissors to cut boldly the rectal nodule between the posterior cervix and the vagina and the anterior rectal wall. Finally, the rectum falls down. Ultimately, 2 layers of fascia of Denonville will open up, and that is the end point, and then do a routine TLH. This is a conservative surgery, which for recurrent endometriosis, we normally start doing a hysteroscopy because this patient wants to fall pregnant. After hysteroscopy, once we go into the laparoscopy, you can see there is adhesions, not that bad though. And each patient we start injecting dilute vasopressin, about 10 units. Then we start with our sigmoid mobilization. That is our routine practice, and opening the ureter at the pelvic brim. So always we should attack the from the pelvic brim, where there is chances of adhesion is less, from always normal to the abnormal tissue. So once we get the ureter, that is identified by peristalsis, the mesentery, the vein, and once we just lateralize the ureter as much as we can, and then we use sharp and blunt dissection. This is, you see how the TO mass is stuck, to pull it out from the adhesions. And this is a combination of sharp and blunt dissection. This is what we use. And finally, you will find out the entire anatomy will be restored. Restoration of anatomy is very important, and then you carry on with your ureteric lateralization. You guard the ureter with your one of the forceps and use your ultrasonic scalpel to lateralize it gently. This is very important to lateralize the ureter, because usually there is a ureteric involvement in the area of the parametrium and the uterosacral ligaments. So you can see the normal tissue. Always try to dissect from normal to the abnormal. The same step is been repeated on the other side. This is also a TO mass. The ovary is stuck with the peritoneum. We are making gentle sniffs to take the ovary out. And finally, you will find the ovary will be freed from the back of the uterus. And then we are using a lot of blunt dissection as well. It's not necessary that you should do ultrasonic scalpel always. And once this is done, you have to lateralize the ureter as well. So this is how the same step been repeated on this side. You lateralize the ureter, and finally you have to attack the rectum. So opening the pararectal spaces between the uterosacral is very important. And you see, this is where the rectum anterior wall is stuck with the posterior cervix and the upper part of the vagina. So it will genuinely, it will drop down once you are in the proper plane. And this is how you just layer by layer, you can use ultrasonic or cold scissors to feel. You can put a sponge on holder in the posterior fornix as well to delineate the vagina. And this is the fascia of Denonville which is opening up. You can appreciate the whole of the rectum will drop, and then you can do the shaving. We are introducing the rectal probe to find out how far the rectum is. And then See, this is the fascia of Dennerville. These are the rectal pillars which are being dissected out, and you shave off the tissues pretty easily. And then this is a patient was for IVF, so we are taking out the hydrosalpinx, and you do a conservative surgery in this patient and excise the uterosacral ligaments and whatever nodule in the rectum as well. So after that, you can use bipolar, and the end point, it should be a very clean field. So I will go for a laparoscopic hysterectomy case.
This is the case.
This is again, as I told you, recurrent endometriosis will have a lot of adhesion. This was an abundant case done in some center, and you can see a lot of dense adhesions in these cases. So this patient had multiple laparotomies for endometriosis. So there will be always a plane. It is for us to find out the plane. And in this situation, cold Caesar is the best instrument. And you will see this is the waterbed sign. You will find this sign between the two bowel loops as well. And you need to dissect well with cold scissors. That is very important. And once you're away from the bowel, then use your energy source. So it's very important. But in these situations, you can make a small nick in the serosa of the bowel. And if, as PDM sir has taught us, that bowel, ureter, bladder are very surgeon friendly. And if you do a bit of stitching, they will heal well. Now you can see, as I told you, all recurrent cases, there will be lot of adhesion. You have to, this is the whole of the bowel, bladder, everything stuck together. You can't see the uterus as well. See, just gentle, we are injecting dilute vasopressin and doing adhesiolysis painstakingly, keep sticking to our own principle, and finally, the ovaries can be seen and the uterus will be seen. So this is how you just go on your adhesiolysis and open up the spaces, open up the lateral pelvic wall. This is the dense bladder which was cocooning the fundus of the uterus and stuck to the bowel. You are doing adhesiolysis, gentle cuts and pushes, and finally the end point will be reached. And you see, we are doing a TLH in this case. This was abundant case because of multiple laparotomies. Patient was suffering like anything. But end result will be good. As I told you, mentally you should have this in your back that there will be a lot of adhesion, and this adhesion needs to be taken down easily. Now this is a routine TLH. We are using ultrasonic scalpel to open up the vault. And finally, the uterus will be removed. And we use a Clermont-Ferrand manipulator in these cases of all endometriosis, because you can manipulate the uterus, correct the retroversion of the uterus as well. And finally, just do the wall stitching. Now, this is another case I wanted to show. This is a very difficult case where the patient has total frozen pelvis and it has a bowel obstruction as well. So very few cases we have done resection anastomosis, but this is one case which was needed for resection anastomosis. So we are going from normal to abnormal plane. See, we are just going from one plane to the other, but we are trying to get hold of the normal tissue. Whenever we are in doubt, we are coming back to the normal tissue. This is a TO mass which we are excising, and this is the lateral pelvic wall which has been opened. So you can see lot of adhesion. As I told, in recurrent endometriosis cases, there will be lot of adhesion. So you just use gentle energy sources, be careful of the bowel, and carry on your dissection in the plane. Hardly you have to know which tissue, which one. This is how you go into the holy plane of the rectum and pull the rectum from one side to the other. I think because of gas, the view is not that good. Now, this is, if you can make out, this is the uterus. Because of multiple surgeries, it's very fibrotic, and we are just going close to the uterus and trying to do the hysterectomy. So that is how we are opening the vault. And once the vault is been opened, we have mobilized the rectosigmoid, and we are taking care of all the nodules from the bowel. And after this is done, we are using, see, this is all involved bowel. We are using a linear stapler to apply in the normal area, low down in the rectum. And finally, we will cut it off. And this is taken out through this is all involved bowel. Can you see? The patient had problems of obstruction, and we are taking it out through the vault which we have opened after hysterectomy. You can appreciate thick nodule. So thick nodule will be taken out, and we are using ultrasonic scalpel to take out the nodule, and also we are using to take out, trim off the fat, such that once we use the circular stapler, they apply well, and there will be less chances of leak. So that is the normal bowel. Now we are doing a bursting stitch to fix the anvil. So once the anvil is fixed, we push it back, and now we fire. You can see we are firing the circular stapler. So, and on top of it, also we give couple of vicryl stitches for stay to prevent leak. So this is how we do the resection anastomosis, but very minimum cases you have to do. You can see the length of the bowel involvement and see how hard this tissue is. All involved bowel having bowel obstruction. So with this, I think one should always, in endometriosis, do a multidisciplinary approach, have at least a urosurgeon and a general colorectal surgeon handy, because once you go in, especially in recurrent endometriosis, there might be a lot of adhesion where you need help. I think with this, I end my presentation. My conclusions will be, so post-surgical, post-operative medical treatment is must. We use, after this kind of surgery, at least 2 to 3 months of medical treatment, because whatever leftover endometriosis should be taken care, and it should heal well. Secondary prevention is defined as intervention to prevent recurrence of pain symptoms or the recurrence of disease in long term, defined as more than 6 months after surgery. The choice of intervention depends on patient's preference, cost, availability, and side effect. So with this, I come to the MCQs. Any questions is more than welcome.
Thank you, Vinesh, for your mesmerizing surgical expertise, which you all very much appreciated. Now, some basic discussion I would like to have in 2 to 3 minutes. Although you have shown in one slide, I would like to know from you what are the apparently basic factors for recurrence for new surgeons which are doing.
Incomplete surgery is the main cause of recurrence.
Sorry?
Incomplete surgery is main cause of recurrence. I have seen many surgeons do surgery and then follow up with GnRH injections year after year. But if you do the first surgery well, then probably the chances of pain recurrence and recurrence of cyst will be much less.
Obviously, and of course, certain factors which are not being removed by surgery, just like stem cell like regeneration or epigenetic changes, which are persistent factors. which you cannot remove, even by doing best surgery by the best surgeon.
Yeah.
Isn't it?
Always you should follow up with medical treatment for at least 2 to 3 months.
Exactly.
That is very
And
important.
second, very good. And second area, there are two types of recurrence. But really understand. One is lesion recurrence, another is symptomatic recurrence. Which one is more common, and what is the combination when you go ahead for the
If the
study?
lesion recurrence without much symptom, the patient won't bother you much. But if the patient's symptoms recur, then they will eat your head after
Because
surgery.
the incidence of symptomatic recurrence is much higher than the lesion recurrence.
Yeah, true.
And lastly, regarding not sparing area, a new area is coming up, that is a neuropelvology.
So with
It's a
the
big area.
these days, once we open the pararectal space, we open it up to the sacral promontory. And we go into the holy plane of the, usually on the left side of the sacral promontory, you can find out the inferior hypogastric, superior hypogastric nerve. It is slightly on the left side of the sacral promontory. You trace it out. It then becomes Y into the left hypogastric and right hypogastric nerve. And then you start dissecting. Nowadays, we have started doing this. We go dissect straight into the sacral promontory, take care of the nerve first, like the ureter, we lateralize. The same thing we have started doing, lateralizing the inferior hypogastric nerve on both sides.
Thank you. This is the area which I wanted to enlighten the viewers. Thank you very much, Abhinesh. If there is any question, they'll put up you in the chat box. And if it is not there, it is over to Ramani Devi or her assistant who is conducting this thing. Jignesh, take it over and hand it over to the question answer area.
Yes, sir. Just give me 1 minute. I will show the question answers.
Thank you all the speakers and my chairperson for excellent conduction, for a very nice and informative session.
Thank you. Thank you.
Thank you very
So
much.
now we have the quiz time. So I request all the audience to participate in this quiz. So Jignesh, you just upload the quiz. Harshini ma'am, you're there?
Yeah, I'm there.
Yeah.
I can just read out the questions.
Good. Here will all the questions, viewers. Here will all the questions will be coming.
Okay. So the diagnosis of endometriosis, kindly select the correct statements. A gold standard is visualization of the peritoneal cavity by laparoscopy. Accuracy of pain symptoms has weight positive predictive value of only 40%. Empirical treatment is suitable for younger patients. CA-125 is elevated in variations of benign and malignant conditions. USG of pelvis can diagnose peritoneal endometriosis. Can you turn off the correct answers for the second one? So ovarian endometrioma, kindly select the correct statements. Multiple answers may be true. Ovarian involvement is encountered in 25% of the cases. Should be operated if the cyst size is greater than 5 centimeter. AMH is usually unaltered. Utmost care should be taken to preserve the vascularity during the surgery. Very high CA-125 indicates only associated malignancy. Laparoscopy surgery for endometriosis. Kindly select the correct statements. Multiple answers may be true. Successful in 30% cases. Surgery partially help in 40% cases. Recurrence is 0 to 5% within 5 years. Ultrasonic energy has the lowest lateral thermal effect. Thermal injuries are highest in bipolar coagulation. So the Endometriosis associated with infertility. Kindly select the correct statements. Multiple answers may be true. Should have initial investigation similar to infertility without endometriosis. Medical therapy should be the first line of treatment. Fertility enhancing procedure is the best option when associated with severe pain. Surgical management is indicated after the failure of ART procedure. Blood for FSH and AMH is mandatory before any decision for surgery is taken. So right answer is A, C, D, and E. Deep infiltrating endometriosis. Kindly select the correct statements. Multiple answers may be true. Is a multifocal pathology. Lesions are isolated and unique. Is less than 10% cases. Can involve bladder and lateral ligaments, uterosacral ligaments, vaginal and bowel. Multidisciplinary approach for diagnosis and treatment is mandatory. Complete surgical excision is necessary. And the right answers are all of the above. Which of the following technique is currently considered most effective in preserving ovarian reserve during surgical management of ovarian endometrioma? Bipolar coagulation of cyst bed, CO2 laser vaporization, cystectomy with extensive cauterization, oophorectomy. And can we reveal the answers? CO2 laser vaporization, B. The three-step technique, Donis technique for endometrioma management involves A. Cyst aspiration followed by GnRH agonist therapy, drainage, GnRH therapy, delayed cystectomy, immediate cystectomy followed by IVF, laser ablation followed by oophorectomy. The answer is B. Drainage, GnRH therapy, and delayed cystectomy. Which of the following methods has been increasingly used as a fertility preserving alternative to cystectomy in selected cases of endometrioma? A. Sclerotherapy with ethanol. B. Ovarian drilling. C. Tubal ligation. D. Endometrial ablation. The answer is A. Sclerotherapy with ethanol. Which of the following statements regarding plasma energy ablation in endometrioma management is true? It produces deeper thermal injury than bipolar coagulation. B. It is associated with higher recurrence rates than cystectomy. C. It allows controlled and superficial tissue vaporization. It is contraindicated in fertility preserving surgery. Reveal the answers. It's C. It allows controlled superficial tissue vaporization. According to the recent fertility preserving strategies, which is when is cystectomy not routinely recommended before IVF? Endometrioma less than 3 to 4 centimeter without symptoms, suspicion of malignancy, severe pelvic pain, rapid cyst growth. Can you reveal the answers? A. Endometrioma less than 3 to 4 centimeter without symptom. A 32-year-old nulliparous woman with severe dysmenorrhea and infertility is diagnosed with bilateral ovarian endometrioma, 5 centimeter each. What is the most appropriate surgical approach to optimize fertility? Drainage and coagulation of the cyst wall, cystectomy with preservation of ovarian cortex, oophorectomy, medical management with GnRH analogs. B. Cystectomy with preservation of ovarian cortex. A patient with deep infiltrating endometriosis involving the rectosigmoid presence with cyclical rectal bleeding and severe pain. Imaging shows greater than 50% of bowel circumferences involved. What is the preferred surgical option? Superficial shaving, discoid resection, segmental bowel resection, medical therapy only. C. Sigmoid bowel resection, segmental bowel resection. During laparoscopic excision of DIE involving the uterosacral ligaments and ureteric proximity, what is the most critical step to prevent ureteric injury? Blind coagulation of the fibrotic tissue, routine ureteric stenting, ureterolysis before excision, avoiding dissection near ureter. D. Ureterolysis before excision. 14. A 38-year-old woman with completed family has severe adenomyosis and DIE not responding to medical therapy. What is the definitive surgical management? Conservative excision of the lesions only, hysterectomy with excision of endometriosis, bilateral oophorectomy alone, and IUS insertion. Hysterectomy with excision of endometriosis. A patient undergoing surgery for recurrent endometriosis after previous cystectomy, what strategy best reduces the recurrence risk? Repeat drainage only, aggressive electrocoagulation of ovary, complete excision of disease with postoperative hormonal suppression, D. Avoid surgery. C. Complete excision of disease with postoperative hormonal suppression. Deep infiltrating endometriosis is defined as lesions infiltrating more than 1 millimeter below the peritoneum, 3 millimeter below the peritoneum, 5 millimeter below the peritoneum through full thickness of organ wall. C. 5 mm below the peritoneum. The most common site of deep infiltrating endometriosis is bladder, rectovaginal septum, uterosacral ligaments, appendix, ureter. So B. Rectovaginal septum and uterosacral ligaments. Ureteric endometriosis with hydronephrosis requires medical therapy alone, observation, surgical intervention, D. IVF. C. Surgical intervention. Preferred approach for bladder endometriosis, medical therapy only, shaving, partial cystectomy with full thickness involvement exists, and hysterectomy. C. Partial cystectomy when full thickness involvement exists. The most common site of deep infiltrating endometriosis is bladder, rectovaginal septum, uterosacral ligaments, appendix, ureter. I think the question is repeated, but still it's okay. It's B, rectovaginal septum and uterosacral ligaments. The quiz time is over, sir. It was a very wonderful session. Thank you, chairpersons and faculty, for giving such an wonderful insights on endometriosis. Thank you so much. Ramani Devi ma'am has also joined us.
I am there right from the beginning, but I'm not well, so I'm a silent observer today. Anyway, for the participants, you will be soon getting the certificate for each session, because we had some issues that has been sorted out. Soon it will be sent, so don't worry, participants. So there many participants were texting me when to get the certificate and where to get it. You can download from your mail, and it will be done within this week, all the sessions together. Thank you so much. And I thank all the participant faculties for having joined today's program. It was a wonderful program, listening to all the senior members. And once again, I thank on behalf of Endo Society of India and for your excellent participation. And I also thank the chairman, Dr. Mahapatra sir, and the Secretary General, Dr. Pratik, for having permitted us to do this program. I thank Harshini for covering up in my absence. And we'll be having the South Zone CME on 17th of May at Tiruchirappalli. And many of the learned faculties in and around Tamil Nadu are joining us, along with Dr. Pratik sir. And soon we are expected to form a chapter of Tiruchirappalli along with the Endometriosis Society of India. Thank you. Thank you all.
Thank you,
One and
ma'am.
again.
Thank you, ma'am.
Thank you. Thank you.